Our next speaker will be Robin Robinson.
Thank you, and I want to thank the organizers for inviting me. I feel like a film critic at the first cut of the director's editing, and looking at an interactive 3D movie with so many different parts going on. BARDA, or the Biomedical Advanced Research and Development Authority, was established in 2006 by the Pandemic and Novel Hazards Preparedness Act, and by mandate, by law, is we are required to support advanced development, and advanced is a real important element to what we do, and to make available medical countermeasures, whether they be vaccines, therapeutics, medical devices, and diagnostics for biological, chemical, radiological, and nuclear threats, pandemic influenza, and other emerging infectious diseases. We are part of the Public Health Emergency Medical Countermeasure Enterprise that Carol talked about earlier. And so we are another component in that, and like Alex said, we, by statute, are required for our CBRN threats to take material threat assessments and determinations from the Department of Homeland Security, and then to do medical consequence analysis and modeling to determine what are the right medical countermeasures, and then what would be the appropriate amounts and types depending on the scenario that we have and the capabilities that one has at any given time. Saying that, we are very important in playing with a number of different vaccines. Our approaches are really depend on what the vaccine and the threat is, but primarily we go through advanced development and supporting that. Secondly, that we go forward with the either stockpiling or building up infrastructure and of that. And so we, and lastly, making sure those are available to hand off to our colleagues at CDC for distribution and administration. So we have looked at prioritization tools. We are further refining a prioritization tool that we have that we use on an annual basis that has basically our scientific advisors, our program managers, and then our subject matter experts, both internal and external, providing input on that. Some things that we really look at are impact, the overall impact versus the risk and feasibility. Those are really two primary drivers, and there are a number of criteria elements that make up those. But also we have to look at cost, and I'll get into that a little bit more with the 5 questions. And we have other programs that have nothing to do with vaccines that are competing, and how we actually prioritize those with that. The other element is that, as Carol pointed out, we actually have strategic documents and directives that we are well on our way with for a number of these threats. The vaccines areas that we have are smallpox, both for healthy and special populations, anthrax, both enhanced licensed vaccine and next generation vaccines, including RPA vaccines, and third, influenza vaccines, in which we go from the gamut of fortifying what we have with existing vaccines to interim solutions with cell and recombinant vaccines, ultimately to have a vaccine that we could use in a limited once or twice in your lifetime as a universal flu vaccine, depending on how you define that. But that's the overall strategy that was put forth in the pandemic and influenza strategy in 2005. Relative to the 5 questions, the usefulness, at BARDA we would find this limited, but would reserve our final opinion to actually we test drive it. One of the things that, from our viewpoint, is the stage of development. This is definitely depending where you are. And advanced development is, we're looking at a winnowing down of those discoveries and proof of concepts that have going into animal studies and at least through a phase 1 study. So we can't take the risk of taking everything that's there. We certainly have input into some of those things that are much earlier, and we certainly watch them coming forward. I would just give you an example. There are 38 different anthrax vaccine candidates in the world, around the world, some of which people are not even supposed to know about, but we've found out about them. We're not supporting all of them, But we have about 10 different ones that we're supporting right now, including taking what we have and making it better, which is very important. The other usefulness element would be the existing vaccines, whether they be, so your competitors, and from my background in industry, we always looked at this. And that would be not only the existing licensed products, but also ones that are in development. So if your anthrax vaccine, you're looking at all 38 of them, you're seeing where they are. And we do landscape mapping all the time and update that frequently with our partners at NIH and also in the Department of Defense. And next is the non-infectious disease, which addresses the scope of this tool. Can you look at something that's a really kind of a hybrid vaccine that approaches infectious diseases and cancer, such as the HPV vaccines, or drug abuse? So would it have applicability in those areas? Next on usability, we'll reserve our thoughts on that after we test drive again. But the first one is about money. And it's not just with industry, but it's also how we are able to use our federal dollars and prioritize that. The first one is life cycle management costs. What does it really cost over not 1 year, but 10, 20 years to have that product, and what it's going to be like? Because sometimes you actually may be replacing it with a better product. So not only the product purchase, but also the expiration dating and the cost of storing it, and also the cost of administering it. And I'll come back to that again. Other money issues include what are the funding sources, the return of investment that we make or industry makes or the nonprofits may put into that. And that depends because it many times is a multitude of different funding sources to get at that ROI. The cost of development, the manufacturing cost, distribution, the product purchase itself, and administration have to be part of this for it to be usability. Mass vaccination for us is, well, we're dealing with tens and hundreds of millions of doses of vaccine going out in an emergency is really important for us. Surge manufacturing capability, how surgical, how fast does it take you to go from the time you know something to the time you actually can turn it around, and can you actually go faster than that? Again, the logistics I've mentioned before, distribution, storage, administration, and what we basically call the vaccine user friendliness. So the usability of the tool actually really does need to look at the user friendliness of this. Data library, we're happy to be able to contribute in any way we can. The more than 35 or 40 different vaccine experiences that we have been supporting. But one thing I would point out is that you have data that's already there. You have successes and you have failures or disasters in vaccine development, and going all the way to the ultimate goals of being able to effectively treat or to prevent diseases. So I would suggest you spike the model. Go back with polio. Go back with, would we say that Edward Jenner's smallpox vaccine, be rated very high on this with this tool. The fourth one is the application development. I'm going to let Tim Lant, who is speaking this afternoon, get into the source code and to some of the modeling details. He'll have some suggestions about that. And lastly, the outreach is, yes, we want to test drive it, and we want to actually test drive it versus our own prioritization tools, and that'll give us a good idea of how much we would be able to utilize this. Thank you.
Thank you. I believe our next speaker is going to address us by telephone. Carter Diggs, Senior Technical Advisor, Malaria Vaccine Development Program. Oh, he's here. Okay. I lost track of who was coming up, but while I'm thinking in terms of those that will be speaking by phone, could I ask you in advance that when you do speak that you step away from sources of electromagnetic interference and perhaps turn off the video monitor that you might be using because of interference purposes. We do have an enormous time delay from what I'm sensing between what is said here and what you're hearing. So if you can make it a real telephone phone call rather than having the delay come in to confuse us, then I think it'll help. And I apologize for thinking you weren't here, Carter. So you're here and alive and well.
It was a rumor.
It was a rumor.
Well, thanks very much. I want to thank the organizing committee of the Institute of Medicine for inviting me to come here today. I'll start with a disclaimer. Whatever I say will be my own opinions and not that of USAID, but I'm happy to be here, and I will speak to USAID to the best of my ability and how they might interact with this tool as it evolves. I was at the first meeting of the committee, however many year and a half to whatever amount of time there was, and I have to say that at that point, I was overwhelmed at the magnitude of the task as it was presented, and very, very skeptical, I think, of really how this would proceed. Looking at it now, at this stage of 0.99 or what beta or whatever you want to call it, I'm very, very impressed with what has happened and with the initiative of the committee to really put together all the latest insights into how to go about building these models and to implement them through the machines. And as Dr. Phelps was speaking, I thought I had this vision. He talked about the decisions being a team effort and stressing the fact that this is a support tool and not a decision-making instrument. But I visualize this team as including, the machine in some way, shape, or form. You could even imagine, something that looked, a robot, if you will, sitting at the table that would enter into this discussion and put forward various views, but more importantly, to really put together the data in a way that human minds can't in an aggregate form when it's this complex. So the complexity issue, I think, is where this kind of an approach can be extremely valuable in the long run. And what we're seeing now, I think, is the first infant steps of what will happen over the next decades. So I think from that point of view, it's a very important initiative. With respect to USAID, USAID is not I would say, vaccine development-centric organization. We do have a couple of very robust programs in malaria and HIV, but as an agency, USAID is concerned, as you know, with implementation of tools that are already available, primarily, although I personally would hope that we increasingly look at R&D and think of the truism that if you always do what you always done, you always get what you always got. So, and we're very, very grateful to our other federal partners, HHS and DOD, that contribute so much to this field. But the decision-making at USAID does concern interventions and not just vaccines, although we all know that vaccines are the most effective preventive measure that we have. We don't have vaccines for many things, and for those things that we do have vaccines, there are still many other interventions that play a role. So really, the attributes that come into play very, very prominently, maybe with 95% strength importance, are the public health need in the developing countries where we work, and the cost, because obviously to fully support the interventions that would be required to take care of the public health needs is way beyond what we can imagine now in terms of budgets. So I think that tools that help make decisions across the whole list of interventions that we have are very important, and to the extent that USAID would be using this kind of technology, it would need to include that. My understanding is that smart vaccines could be considered smart interventions, and it could be used in that way, and that might be a very important thing to look at in the long term in terms of USAID use. I'll just comment on the data question. It seems to me that much of the data that's required for input really is the same data that we need for surveillance in terms of evaluation of programs that are in place. So to the extent that resources could be used to serve both of those needs, and I know that the overlap is not complete, that would be very, very useful. I think I'll stop at that point. Thanks again for having me here to make a couple of comments.
Well, thank you very much. Now, Richard Martinello is on the phone, I believe?
Yes.
Okay, you're coming through well, so I'll turn it over to you.
Okay, thank you very much. And the first I want to apologize I wasn't able to be with the group today. But thank you very much for allowing me to provide our comments by phone. We do commend the committee and the IOM for tackling such a broad and challenging task. Thanks to the group allowing us to provide our comments. PA is a major vaccine domestically, not directly about identifying vaccine prioritizing for development. So service delivery across the United Territories, over 1,300. That's what it's still for the purpose. While we put color, guys, recommendations.
Richard, if I could interrupt, the audio is not coming through terribly clear. Is there anything you guys in the back of the room can do to maybe kill some of the echo, or? Yeah, it's chopping. Yeah, it's chopping. Are you on a telephone?
Is this better?
Are you on a telephone, or are you on a?
I am on the telephone.
Okay, do you want to start speaking again? And
Yes, okay. While VA closely follows ACIP recommendations and the recommendations from other federal stakeholders and those of recommendations from National Professional Organizations, we do anticipate that we will be using the smart vaccine tool for a minor portion of our decision support in the future. Specifically, we anticipate that smart vaccines may be used when VA considers adopting a vaccine for use. Again, while we generally follow ACIP recommendations, we do need to take these recommendations and the recommendations of other organizations into consideration when we make decisions on how VA will recommend the use of a specific vaccine product. The primary mission of VA is to care for veterans. As such, in prioritizing vaccines, we highly weight the burden of disease in our veteran population, the potential benefit of the vaccine, its cost effectiveness, and its cost benefit. As with any other healthcare entity, our resources are limited, and we must make these decisions based on what is best for our veteran patients and how it weighs in against other priorities that our system has. We are very pleased to see that many of the attributes that weigh into our decisions are contained within the smart vaccine software decision support tool. I did want to make a few comments on the usability question, the data library, and the development of the application. One way that VA has changed over the last 10 years is in how we provide care to our patients. Not only has there been a major shift from focus on inpatient hospital care towards outpatient care, but also VA is increasingly providing care to veterans in their homes. As such, cold chain issues are becoming of increasing importance to VA. As we reviewed the smart vaccines application, we did have some other comments that we would like to share. First, one thing we would like the community to consider is creating the ability to know the source of attribute data entered into the system, such that the report generated by smart vaccines can contain and/or save the user's notes or references for specific data points. Generating high-quality data that can be entered into the system is critically important, and having the ability to have it clearly documented and saved within the report may be very useful to the user. that the committee put in a lot of work to identify best quality data sources, and many of those examples are presented in the phase 1 report. It appears to us that this data will be available once the Smart Vaccines product becomes available broadly. But we would like the committee to consider embedding not only that data and its references for users to be able to use when they use the application, but also to provide an example to users of the type of high-quality data and the type of data points that should be used when using Smart Vaccines. We would also like the committee to consider adding in specific examples of how the tool may be used. Some examples that we would like the committee to consider include when one is thinking of a smallpox or anthrax vaccine for civilian population. Typically, the risk for either of these diseases is essentially zero, with the exception of the possibility of an intentional release of this pathogen. How will these products be considered within the framework of Smart Vaccines? Second, we would like the committee to also provide an example of how future vaccine candidates would be considered within Smart Vaccines, where the benefit of those vaccines is not homogeneous over age strata. So, for example, if an RSV vaccine candidate or a group B strep vaccine candidate became available for further development, generally those vaccines are directed toward pediatric populations. The VA system primarily cares for adult patients. How could we potentially consider the benefit of these vaccines within the Smart Vaccines framework for our adult patient population? What is the proper way to approach this question with Smart Vaccines? Finally, we would like the committee to consider further development of the product to allow a user-defined attribute to be added. One example that we would like to bring up for consideration is the ability for Smart Vaccines to consider how a vaccine may modify disease as opposed to necessarily preventing a death or preventing an incident case. So, for example, would it be possible to create a user-defined attribute that would allow the ability to enter data on how many hospitalizations may be prevented or how many days of work or school may be saved through the use of that vaccine? Finally, I'd just like to comment that VA could potentially serve as a very rich source for high-quality data to better understand disease burden, vaccine effectiveness, and safety of this vaccine. And we would be very happy to have further conversation on how this data could potentially be included in data library for Smart Vaccines in the future. I will go ahead and conclude my comments there. Again, I'd like to thank the group for allowing us to speak today.
Well, thank you very much, and perhaps this is a minor violation of protocol, but as you were asking questions about what Smart Vaccines could do, had you been sitting on stage, you would have seen Dr. Phelps nodding his head affirmatively on essentially all of your questions. So, for what it's worth, you struck a chord with him, and he seems to think that those questions can be accommodated. Our next speaker is Patricia Quinlisk from Medical Director, Iowa Department of Health, and my next-door neighbor in Minnesota.
There you go. Okay. I'd like to thank everybody for allowing me to come today and talk a little bit about Smart Vaccines from a state perspective. When we are doing or using vaccines out in the state, probably the thing that is most important to us is the community aspect. Sort of what does the community think about the vaccine? What is their acceptance of the vaccine? And then from our standpoint, just the practical or applicable nature of the vaccine. Is it something that we can easily get out to people? Is it easy to store, et cetera? So today, I'm probably not going to really talk about the development of vaccines, et cetera. I don't know that the states per se will have much say in exactly which vaccines are targeted for development, but the implementation of those vaccines, particularly around the policy of implementation, of course, is very important down at a state level. So the things that I deal with most is the community desire for a vaccine, the individual assessment of the disease risk of the disease, the individual's assessment of the risk of the vaccine, and that can be include things that are under our control, such as the use of adjuvants, or things that are not under our control, such as a spokesperson who gets up and speaks for or against a particular vaccine. The other thing that we don't have control over is the public's perception of the disease and whether it's high profile or something they consider themselves to be at risk for. So I'm going to go through these things again from a state perspective and just give you a little bit of my thoughts on it. As far as the usefulness of smart vaccines, again, from my standpoint, determining which vaccines shall be developed is not something I probably would be very involved in. But looking at this model to help us in the states to understand the impact of disease, to understand what kind of public information might be available, et cetera, that kind of information would be very useful at the state level, especially when we get into the economics. One of the things that I've seen change over the last 10 or 15 years is people becoming much more concerned about the economic costs and the issues around any kind of public health intervention. So one of the things when I was looking through this is I was wondering if this model might be used, for example, to go to an insurance company or a school system to say, should you in your population use this vaccine, would this model be able for me to pull out and say, oh, if you, large business, use this vaccine, it would prevent this many employee absenteeisms and save you this much money on your insurance, something like that. That kind of model, I think, would be very useful. Also, I think this model might be useful for us at the state level when we have limited resources and might be looking at 2 different possible vaccines to implement a strategy on to help us look at exactly what kind of impact it's going to have on that community, determined by which of the competing vaccines we might use. When I looked at usability, again, we look at what are the public concerns. And I know in your model you look at things like alternative health measures. When I was looking at that, one of the things that it reminded me of was the Lyme disease vaccine that we did have available a while ago, but didn't seem to be very successful. And one of the things that I did here in a state that not only has Lyme disease but has quite a bit of mosquito-borne diseases was that, yes, I could use the Lyme disease vaccine, but I'm still going to have to use insect repellent because there's West Nile and all of these other things, and since I have to use that anyway, that will prevent Lyme disease, so why would I bother getting the vaccine? So I do think those kind of things are very important to put into a model. Also, as we all know, there's a lot of individual concerns about ability of vaccines, and I know you have some of this in the model, just the whole issues around adjuvants, mercury, aluminum, et cetera, and that kind of thing is going to make a huge impact at the community level as to whether or not the vaccine is accepted. One of the things I did not really see specifically in the model that I do think does make a difference, and I don't know quite what to call it, but sort of the stigma of the vaccine. I'm always amazed with the HPV vaccine and people's thoughts about, well, if they get the vaccine, then what we're really telling teenagers is they can go out and have unlimited sex. I think we all understand that's not the reason we make a vaccine, and that's not necessarily what happens, but again, that kind of thought process and information that's out there in the community definitely impacts the acceptability of the vaccine. So one of the questions I would have about this model is, can this model help us to predict some of those things? Because if we can have a model that helps predict some of these issues that might come up, it would help us to get ahead of them perhaps and do pre-education so that we don't have as much impact of those things on the community once we start implementing a vaccine strategy. Next, looking at the data library, again, at a state level, I don't know that we're the ones who would ever be determining some of those issues that would go into that model. I really think that's going to be needed to be done by experts in the field at the national level. But I do think it would be very important once some of those determinations are put into the model for us then to go at a state level and put in our state demographics and that kind of thing. Those demographics we do have at the state level, obviously, through census data and things, and it would be very interesting then for me to be able to say here in Iowa, this is the impact that this vaccine, if we developed it, would have on my state. So that kind of thing, I love the flexibility of this model allowing me to look at just the population over which I do have basic responsibility. And I think other states would find that kind of thing also very useful. And I think it would be useful for us to be able to look at the resources needed in some of these models, because when we talk about implementing some kind of vaccine policy at the state level, it often comes down to, is it feasible? Do we have the resources? Do we have the money? Do we have the political will? It really doesn't, a lot of it doesn't depend on the people, the community, and what they want. It really depends on, can we get, for example, right now we're trying to get adolescent mandatory vaccination of Tdap in order to try to reduce our pertussis rates in Iowa. And that really has very little to do, to be honest, with the community. Really has to do more with the will of the policymakers. One of the things, too, when I was looking at this model that I thought would be very interesting, and I don't know if this is what you thought about doing with the model, but would be something for us to look at before and after, before a vaccine program and after. And I'm thinking sort of several years ago, as we had a huge mumps pandemic or epidemic that came out of Iowa, and it would have been very interesting to use a model like this to say, if we go in and vaccinate this many college students, what kind of impact will we have on our communities, and will it do what we think it's going to do? And again, I think that the applicability of this at a smaller population level, such as those within a particular medical system's watershed area or a particular large company or something like that, I think that might be very interesting, and they might be very interested in seeing if we could pull out of the model an economic impact for that group. So that's some of the application development. Again, the comparison and the economic impact, I think, might be very useful. That would more likely come after a vaccine were actually developed and available. Again, I think something that when we look at the data elements, again, I think that we would have to have somebody else put the data elements in. I don't see the states having the ability to determine some of those data elements. So again, we would probably be most likely using this kind of a model to help predict what was going to happen once a vaccine might become available. Also, we were asked about outreach. How would we get this word out to states? If this model did become a kind of model to help states predict what would happen in their states economically, resource, and with the vaccine or the disease impact, I think that would be something that the states would be very interested in, and the easiest way, I think, to get the word out would be to demonstrate this model and what it could do at national conferences, in articles, and that kind of thing. And I think for the policymakers at the state level, it would be best to, through the people working in state health departments or local health departments, having them access to the model so they could go and demonstrate it to the policymakers. At the end, we were asked about what might be the potential for this. Again, when I'm looking at the community public health level, the model, I think, would be very useful, and it might be also useful if we could put in some of the complementary strategies that we use to try to control diseases, to augment the disease control that started with the use of the vaccine. Also, I think it might help at the state level to identify areas of concern such as supply and difficulty of storage. And I wanted to take just a minute about the storage. This continues to be an ever-present challenge at the state level, as well as the national levels. I'm sure most of you know a lot of vaccine is wasted because of inadequate storage issues. And I'll just give you an example. We recently just had one clinic alone that had a storage issue. We had to throw away $18,000 worth of vaccine. It cost us $66,000 just to provide the children with replacement vaccine, and overall cost us over $200,000 in staff time and vaccine to make up for a storage error, and that was in one clinic alone. Some kind of model like this might be very useful, not just to look at a particular vaccine, but to come back to Iowa or a place like a state and say if we would be able to make a vaccine that had a better storage profile, that it could withstand wider variations of temperature and only cost 5 cents more per person. Is this something that the state would be interested in buying? Is this something that a person in a private clinic would be interested in buying because of these problems that we do have with storage? And I know most people think storage issues are educational issues, but I'll just tell you, one of the problems we have is it's usually the office manager who's told to write down the temperatures of the refrigerators. And so they write it down every day, and they write it down in the red area that says take action immediately, and they keep on writing it down in that area for a year and a half, and finally somebody else sees it, and they said, oh, well, I was just told to write it down. And so education has its limits. It would be nice to have a vaccine that was a little bit more stable. Lastly, I would just like to, again, sort of end with the whole economic issue. I found that more and more what I'm being asked by the policymakers is for me to make the economic argument. In fact, the last several EPI-AIDS we've asked for from CDC have all been on economic impact, because that's what the policymakers want me to talk to them about. So I think the more we could talk about and provide clear information on the economic impact through using a model like this, I think the better off we're going to be when we start talking to the policies makers who give us the money to make the vaccines. Thank you very much.
Thank you very much. Before moving on to David Hammer, I just want to thank you, Patricia, for introducing what I think is a new twist on smart vaccines, and that is to use it with the cadre of available vaccines that you have to prioritize your various campaigns around and decide to marshal your resources toward disease X, but perhaps a lesser interest in disease Y based on something that's peculiar to the, in your case, the Iowa circumstance. So that was very good. David, are you there? David Hammer? Okay, we'll try to come back to him later. Dr. Kulkarni, are you there?
Yes, I'm there.
The microphone is yours.
Okay. Good morning, everybody. Thank you very much for giving us this opportunity to talk on this project. I belong to of India, which is a developing country vaccine manufacturer and one of the biggest.
Excuse me for interrupting. We're having a similar issue with your signal as compared to an earlier phone. Are you just on a telephone?
I'm on a telephone.
Yes, see if you can just speak into the phone and see if it gets any better.
Okay.
Okay, keep
Is
going.
this better or no?
Yeah, keep going.
Okay. For a developing country vaccine manufacturer, what is important is the directives of WHO, which basically caters to the needs of the developing country. And as I had mentioned in last year's presentation, WHO has got its priority list in terms of recommending them at the EPIs of various countries. So they have high, medium, and low priority vaccines. And this list is of particular interest to developing country vaccine manufacturers. And keeping that in mind, what we find is that, of course, the tool, the smart vaccine tool, is definitely very helpful regarding new vaccine development and prioritization. Hello?
Yep, keep going.
Okay. So what we that this is no doubt it has got a huge value and will be very useful. Basically, the policy, and because for manufacturers, their strategy is driven by the recommendations of the policy makers. So we definitely feel that this kind of tool will be highly useful to these policy makers and in turn to vaccine manufacturers. I think, of course, this is supposed to be just a supporting tool.
Yeah, excuse me, you're drifting in and out, so perhaps if you can hold the speaker more consistently and
Sure.
that might help.
Sorry. Okay. So, what I was telling was that if this tool was supposed to be a more of a supporting tool to help making decisions, I really wish if it could really give some kind of real recommendations in terms of hello.
Yep.
Making prioritization, but I can understand the constraints. So so this is the situation, and of course, as anybody can understand, the needs of the developing and the developed world are totally different, and naturally, even among the developing countries, there could be some regional differences, and and another limiting factor is that in most of the developing world, in many of these countries where there is a lack of surveillance system in place, the inputs that are required for the model to work are oftentimes not available, and that could be a challenge, and that must be kept in mind, especially when we are trying to extrapolate data from some other country, some other community to one community of interest that may not always hold true for the community in question. So these kind of things have to be kept in mind, and as regards vaccine development, as I said before, that because for the vaccine manufacturers it is important that the recommendations of the World Health bodies are taken into account, so that they are the vaccines that are developed are of relevance to the communities who need these vaccines. So I'm sure that this tool will be of interest to those policy makers. And as far as the current software version, whether it is user friendly or not, I'm not in the position at the moment to tell, because honestly I've not really used it myself, so I can't comment. But from what I see from the report, it does seem to have definite user-friendly approach, but maybe could be made better so as to take into account the various levels of users that may be using particular tool. And as far as the data library, hello?
Yes?
Okay. How should the committee address the intensive needs for data inputs into the model? That is the big question. As I already mentioned, there's a definite lack of data, especially in the countries where the disease burden is very, very high, both in terms of morbidity, mortality, as well as in terms of the economic impact. And that is where we need to be very, very careful. And maybe that underlies the need for more surveillance, more rigorous surveillance, and more cost effectiveness studies in those settings where those vaccines are needed most. And so this is what I would like to comment from a developing country vaccine manufacturer perspective. And if those particular aspects relevant to the poor and the middle income countries are taken into account, I think this will be a very valuable tool to all the decision makers. Thank you very much.
Well, thank you very much. Is David Hammer on the line by any chance? Okay. Well, we have a few minutes left in this session. I have a question, if I could pose it to you, Philip Krause, from the FDA. You know, as you were speaking, the thought came up as a tool of the nature that has been described for smart vaccines. Would this software package fall under the FDA's responsibility for approving, or is it so far upstream that it's a tool and not something that makes a decision per se?
So I'm not a part of the FDA that makes that decision, but I can tell you for sure that that it's far enough upstream that it wouldn't require FDA approval. So the FDA approves devices or software that will influence patient care directly. And so a decision support tool, for instance, regarding which vaccine somebody might choose to develop would not need to be approved by the FDA.
And can we hold you? No, I'm just teasing. That would have been my thought too, but I just wanted to verify that. You know, there's always the possibility that somebody will want to use this thing blindly and rely on it, but I think that's a very remote possibility with all of the other players and actors that are in the decision-making process.
I mean, I would assume that this tool wouldn't supplant, obviously, the FDA approval process, which would determine what products are licensed and can be used and can be marketed and advertised, and it wouldn't supplant the vaccine recommendation process, which officially is done by the Advisory Committee on Immunization Practices to the CDC. It wouldn't supplant the recommendations that come from various other professional organizations regarding what they recommend that physicians do. And so I don't see a danger of it becoming something that would likely lead to direct interference with those kinds of recommendations.
Right, thank you very much. Another question, in listening to the individual respondents this morning, it seems that one of the benefits of smart vaccines could well be the ability to use it as a thought process communication tool across various platforms of interest, and that you know, when you do make decisions, in Group A, those decisions quickly become opaque. That process quickly becomes opaque to Group B. But if properly used and the attribute sets get frozen for that eventual decision, that smart vaccines has the ability to let other people in on the thought process and the trade-offs that were made, and then if they disagree, they have the ability to go back to Group A and say, but we think attribute B is more important than what you selected, or you need to change the priority. So the question is, can smart vaccines, as you now envision it, be a way to more quickly and more transparently share the thought processes across different units in a way that would minimize second guessing and the yeah but kinds of confrontations that can often happen when you are setting some predictive strategies?
So maybe I'm the wrong person to take the first crack at that, but if I think about our data needs and the way that we think about our decisions, the inputs are enormous. There are a lot more inputs than you can easily encompass in the 27 or 28 major factors that are used in the Smart Vaccines program. So I think if we're going to persuasively explain to people why we make the decisions that we need to obviously be able to call on hundreds, if not thousands, of facts and factors. And all of them in any individual situation might play some role in the final decision. And so it's hard for me to imagine at the very high level at which the Smart Vaccines program is integrating information that would provide enough information to somebody about why a specific decision was made to be that helpful. Because I think what you heard from all of us is I think everybody sees different potential data needs. For instance, if I think about Patricia's very nice presentation, the way in which someone in Iowa or might decide which vaccines need to be used and tailor that to the people in Iowa. Well, to do that, you need to understand for the specific disease, what's the force of infection among different age groups, what are the degree to which people in different age groups associate with one another, what is the distribution of the age groups, what's the vaccine effectiveness in all of the different age groups. For an HPV vaccine, you might need to understand the relative ages at which people first begin sexual intercourse. And so you're talking then about a much deeper epidemiological model that addresses those underlying issues, I think, than you get by ranking or by taking the inputs of these many high-level priorities. And it just struck me, so those were, of course, the considerations that might lead to the kind of decision support that one might need in a public health setting, but the kind of decision support that one might desire in another setting might be completely different and use completely different inputs. And so I'm not sure that the very high-level inputs of the program necessarily facilitate those conversations.
Okay. Thank you. Anybody else want to respond to that? Okay. I'm having trouble reading this. Why don't you ask the question? Okay.
Regimes versus vaccines, how do they make those kinds of decisions? And is there something that the software might do in the future to be able to be helpful?
How do you make decisions on other types of health issues and in addition to or beyond vaccines, and how might this software package help that?
Try to answer that a little bit. And I think these are things we all know. It's easier to build on something that people are already doing. So if there's an intervention that's already partially done, it's easier than to add something to that. It's easier to add things that make sense to people. It's also easier to add a behavior if the people perceive the risk to be high. I mean, there's a lot of things that go into that. The example I used was Lyme disease. I mean, we've been telling people for years to wear insect repellent, and every time we have a person who dies of Lyme disease, we publicize it to increase the awareness of this can be a serious disease, et cetera. I'm sorry, I was talking about West Nile, but then when the Lyme disease vaccine came out, while we do have Lyme disease in Iowa and people get very sick with it, at least the feedback I got was, why should I take a vaccine when I'm already doing something to prevent it? So I think it's very complicated, but I do think a model like this could be very helpful, especially if we're trying to stop a disease. For example, when we had mumps, we were also trying to get people to stay home when they were ill. We do that with flu, though that doesn't seem to work very well. But, you know, cover your mouth and nose when you cough and sneeze, all of those things. Be interesting to see a model like this to see if it could have almost an additive effect and say, if you use the vaccine this way in this population, but also you did these things, this is the additive effect it could have on the population with this amount of morbidity and mortality being reduced. And not just think that vaccines are used in isolation. I think that'd be very useful to people who do things like me in policy development.
Thank you. I think it was Melinda that used the phrase that smart vaccines could have utility in leveling the decision-making playing field. Would you like to expand on that?
I guess the question is who's making the decision or who's having the conversation, but it does seem to me that this kind of a tool provides a framework to think about very different kinds of vaccines that have different attributes, might be used in different populations, have different predicted efficacy and effectiveness. You might be able to achieve different coverage. You might have different programmatic feasibility. You know, all of those things differ and probably have different people who are the experts in them as well. And so a tool, a framework like this could provide a way to, in a summary way, present the expected health outcome of certain interventions of certain characteristics, assuming the assumptions were correct. And there's a lot of ifs in that. But it is a way to provide that kind of summary information to think about very different kinds of products. Now, I think the sort of challenge you've heard from all of us is that isn't sort of how things work. It's not how, you know, we necessarily do our business. But such a framework can allow a explicit set of assumptions to make assessments of expected health impact given those assumptions. And that seems to me that there's value there in being able to do that.
Anybody else want to comment on that? Yeah, you know, as I think back on my former life in a medical device company, one of the toughest times of the year was budgeting time, as I'm sure it is with you as well. And we would have this very attractive list of opportunities, things that we could work on in R&D. And the issue always came up that the ability to do an apples-to-apples kind of comparison between and among products or research projects that all fit the company, but had different champions and had different levels of understanding and articulation for why it's worth working on this one and not that one. You know, I can see this model being adapted for an R&D organization in this case medical devices, where it would not make decisions, but it would allow people to better understand how various presenting groups in the organization have come to the conclusion that this is the project, or these are the projects that we ought to pursue, which by implication means those are the ones that we will not. And it creates that ability to then push back. And I can see that this has the ability to have a quiet voice gain volume by virtue of being able to react to a specific set of decision criteria or attributes, and be better able to argue in favor of something that really should be looked at more seriously. Question?
Phyllis Arthur with Bio. My question is actually about comparing the smart vaccines use to the use of some of the systems that are used to make recommendations like GRADE and the ACIP process. Can you speak a little bit about your vision of how these two processes would compare and contrast or work together?
I assume that was to me. Well, it's certainly the factors the Advisory Committee on Immunization Practices considers in making its recommendations are paralleled to a large extent in this framework. And I think that's no surprise, because that's how we think about benefits of vaccination. What's the disease burden? What's the expected efficacy and effectiveness? Is it feasible? Is it going to be acceptable? Is it expected to be, is it safe? That's how we think about vaccines. That's how and those are factors that the committee considers in making its recommendations, along with cost effectiveness. So the fact that many of the same issues that the Advisory Committee on Immunization Practices considers in making vaccine recommendations, in fact, are reflected in this, I think, isn't a surprise. Of course, ACIP has the advantage of dealing with licensed products, so we do have all of that pre-licensure experience and sometimes even post-licensure experience when ACIP is making those recommendations, so we're dealing with much less uncertainty. But this is how we think about vaccines, and I think that I think that the developers of the models did a good job of capturing the way we think about vaccines, which is very complicated, and allowing for different weights, different attributes to receive different weights, which also is how people think about vaccines. I think the challenge is that the thinking about vaccines is done in lots of different places in lots of different ways, and not necessarily within this type of framework, although clearly you've heard there are certain points where people are trying to make decisions based on coming up with a good decision where they're basing it on health impact and feasibility and acceptability and all those kinds of things. Patty talked about that in Iowa. That's how we make decisions in public health. So the fact that this parallels that, I think, reflects that the designers did a good job of capturing the relevant elements.
Well, with that, we're exactly on schedule. And first of all, I want to thank the panelists, both here and the remote people, for participating and giving us their valuable insights. So I want to thank them. And a housekeeping detail, we're going to break for lunch now. Lunch is available downstairs in the refectory for those that want to go down there. The webcast will conclude right now, but we'll resume at 12:58 Eastern for the afternoon sessions. Thank you very much.